Yes, sir.
Is it okay?
Good,
Yes,
good.
sir.
Go ahead.
Okay. So I think, as has been said by Professor Rao, there is a renewed interest in hepatocellular cancer in recent times, and that is for a number of reasons. Not that it is a new problem, but we have got now better tools to diagnose this condition. We've all realized over decades that this is one cancer which can present in a very dramatic manner and can kill a patient very quickly. And we all know that hepatocellular cancer, or HCC, accounts for almost 4/5 of all primary liver cancers. And the risk factors have been recognized since a long time, and they are the hepatotropic viruses, mainly hepatitis B, hepatitis C. And then also in recent times, there has been a resurgence in the occurrence of hepatocellular cancer due to NAFLD-NASH cirrhosis and alcohol-related liver disease. Now, even though this cancer might not be the commonest cancer, but when it comes to mortality due to any malignancy, this ranks in the top 3 to 4. And the mortality for HCC has actually been increasing, while for other cancers, it has been declining in the last 1.5 decades. So in some years, this is the second commonest cancer, second only to pancreatic cancer, and at times third commonest cancer causing mortality, third to both pancreatic as well as lung cancer. And it's also very peculiar that worldwide, almost 800,000 cases get reported on an annual basis, and an equal number of patients succumb to this tumor on an annual basis. So this is the figure that you see for the year 2018, wherein about 800,000 deaths were accounted for by HCC. And if you have somebody presenting with advanced stage HCC, then the median survival of these patients is less than 1 year. And during the course of the talk, we would be going through what are the various stages of presentation. But advanced HCC patients have got a very abysmal survival. Now, almost 3/4 of all HCCs, they occur in Asia, and China probably accounts for almost 45 to 50% of these cases. The global prevalence is very variable. In US, it is 16 per 100,000 population, but there are parts of US where again there is a high immigrant Chinese population, where the prevalence might be as high as you see in Asia, which is about 25 to 35 per 100,000. It's a male skewed dominant tumor, and the male to female ratio has been pegged anywhere in various studies from 2.5 to 4:1. What are the common etiologic agents? Again, in our own subcontinent, there is a difference. So in most of the parts of the Eastern Hemisphere, hepatitis B accounts for the bulk of the tumors occurring due to this virus. The HCC is occurring due to this virus. And so is the case in India. But in other countries, especially our neighbor Pakistan, the commonest cause of HCC again is hepatitis C rather than hepatitis B. Similarly, in Japan, there is almost an equal distribution of tumors occurring due to hepatitis B and hepatitis C. And in that way, Japan is a little different from the other countries in the Eastern Hemisphere. It is the 5th commonest cancer in men and the 9th commonest cancer in women. So, and what about the epidemiology of this tumor in our country? Again, we don't have any community-based data or registry data. Please remember that this is not a notifiable disease. And this was a publication from All India Institute about 7 years ago, wherein the authors reported that the incidence amongst men is about 0.7 to 7.5 per 100,000 per year, and in women is 0.2 to 2.2 per 100,000 per year. The mortality rate in men is slightly higher than the mortality rate in women, and it's anywhere from 5 to 7 per 100,000 year. And I've already alluded to the male dominance of this tumor. The age of presentation is between 40 to 70 years, and younger the patients who present with HCC, greater the chance that they would not have cirrhosis as the background liver disease when they present with HCC. And again, in this study, they found that the commonest etiologic agent was hepatitis B virus. So when you are faced with the patient in the clinic, a liver disease patient in the clinic, what do you do? So etiology of the liver disease is extremely important. And therefore, we must remember that the patient sitting in front of us, we should not only just know the viral characteristics of that patient, but also what stage of liver disease the patient is in. And this has got some far-reaching consequences when it comes to surveillance strategies. So in the context of hepatitis B, if the patient presents with cirrhosis, the annual incidence is anywhere from 3 to 8%. But if it is an Asian male who is just HBsAg positive but more than 40 years of age, this incidence could be anywhere from 0.4 to 0.6. If it's an Asian female, the HCC occurrence is more common in the sixth decade, that is beyond 50 years of age, and this is about 0.3 to 0.6%. So this is very important because there are scores online calculators like the REACH-B calculator, which is something that we use very commonly to predict the occurrence of tumor in a given patient. So it's very important that just the mere positivity of HBsAg with advancing age. So this patient needs to be on your radar, and this patient must be subjected to surveillance strategies based on what stage of the liver disease he is in. In various parts of the world, the cirrhosis associated with hepatitis C also carries almost a similar kind of an annual incidence of 3 to 5%. It's also important to remember that when we treat patients with hepatitis C with DAAs, and all of us are extremely gratified by the response rates of these DAs, which is anywhere to the tune of 92 to 95% SVR, which is sustained virologic response. We must remember that if these patients have been treated at the stage of cirrhosis, these patients must continue to remain under surveillance. So this is a very important message, that just because somebody has become a viremic or just because somebody has achieved an SVR does not mean that we stop short on our surveillance strategies. So much so that the EASL also recommends the surveillance strategies to be in place for F3 fibrosis. And maybe during the panel, we can talk about how to distinguish between F3 and F4, which even in the best of hands at times can be a very uphill task. But suffice it to say that even though the incidence with F3 fibrosis is slightly less than F4 fibrosis or cirrhosis, which is intuitive, but even these patients need to be under constant surveillance. And then some uncommon genetic disorders, not so common in our clinical practice, including hemochromatosis, alpha-1 antitrypsin deficiency, so on and so forth. So it is extremely important to know that cirrhosis from any cause is the most common cause of HCC occurrence. And worldwide, hepatitis B and hepatitis C, and in some parts of sub-Saharan Africa, still the occurrence of HCC, because aflatoxin being the agent which is implicated, is quite common. And in recent years, there has been again a resurgence of the obesity epidemic, and in that context, the NAFLD-NASH related liver disease. And mind you, some of the patients with NAFLD-NASH related liver disease might not even be cirrhotics when they develop the HCC. And then again, alcohol use disorder related liver disease, that is very common cause of HCC, and which is seen now worldwide. Now, in earlier years, it was believed that alcohol-related liver disease is not so common, and there needed to be the hepatotropic viruses on board to cause HCC. So if you were to look at only pure AUD-related etiology, it would be anywhere from 2 to 4%. But if it was a synergy between the hepatotropic viruses and alcohol use disorder, then the occurrence of HCC was more common, again anywhere from 4 to 8%. So we see this recent resurgence of AUD-related HCC, and I think this is again something which should not be taken on face value, and there is something more to this being the etiology, rather than just saying that the alcohol use disorder has changed or something else has changed. So I think this is something that needs discussion and cannot be taken on its face value, that suddenly when you have alcohol as the etiology of liver disease, the occurrence of HCC has gone up. Peculiar to our part of the world is also hepatic venous outflow tract obstruction, and it is extremely important that long duration of HVOTOs, especially long segments obstruction or involvement of IVC or involvement of both hepatic veins and IVC, it predisposes to the occurrence of HCC. And this is one group of patients in whom imaging can be very taxing, as we will see in the latter part of this talk. And therefore, it is very important to have a very low threshold for going with the cross-sectional imaging, keeping these patients on follow-up, using the tumor markers, and any modality that you might have at your disposal to be able to diagnose HCC in this setting. Now, quickly changing gears and coming to the diagnosis of HCC. So again, this is one tumor, and this is very contrary to conventional oncologic practice, where you can diagnose a malignancy without any histological proof. So the mainstay of diagnosis of HCC has been imaging over the years, and in more recent times, all of us have got familiar with the terminology called LIRADS. We no longer call space occupying lesion in the liver a lesion, we call it an observation. And then this LIRADS has evolved over a period of time, and in its most recent version of 2018, it has set the framework or the lexicon in which all these observations should be reported, so that the person who's reporting and the person for whom it is being reported, they are on a common page. So this is a common lexicon for the radiologist, for the pathologist, for the clinician, whether it's a hepatologist or a surgeon, so that they all know what is being talked about. Now, these are the various diagnostic categories for the LIRADS. So the first one, as you can see at the top of this slide, is LIRADS non-categorizable. So either the imaging was not of proper quality, or the images are degraded and they cannot be used to report with certainty what the characteristics of this observation are. Then you see the top three rectangles, which are LR1, LR2, LR3. So most of the LR1 and LR2 are definitely or probably benign. That means the radiologist is almost certain that this observation is not a malignant observation, and therefore these patients can be just kept on follow-up. And most of these are like cyst, hemangiomas, and at times benign space occupying lesions of the liver. LR3 has got an intermediate probability of malignancy, and when somebody is diagnosed with LR3, and if there is background liver disease, whether it is chronic hepatitis or cirrhosis, we try to manage these patients by offering them an earlier imaging modality. So rather than imaging them, say, at 6 months for surveillance, you might want to do it sooner, maybe 3 months. And if you find that even the other ancillary investigations like tumor markers are available to you, and they are also not in the normal range, you might want to do it even sooner than that. Then you see these two rectangles and a vertical rectangle, which is LR4 and LR5, denoting probable HCC and a definite HCC. And then on the left-hand side, you see the large vertical rectangle, which is LIRADS malignancy. So this basically means that the imaging is suggestive of a malignant observation, and this need not necessarily be HCC. So that means you cannot categorically say that this patient has got a HCC, but the imaging characteristics are akin to that of imaging of a malignant observation. And lastly, you see in the black an LR tumor in vein. So again, this is very common for HCC, and we all know that this has got prognostic significance. This is a tumor which has got a predilection for the portal vein and the hepatic veins. And if the lesion is contiguous, then you're almost certain, and the portal vein also shows the same kind of imaging features as you see in the lesion in the parenchyma, then you know that what you are seeing in the portal vein is a PVTT, or portal vein tumor thrombus. So most of the description for the space occupying lesions in the liver would be characterized by these categories of LIRADS. So now this is a very important slide, and I think all of us can keep it on our desktops or on our workstations. So please remember that LIRADS does not give you any handle on which investigation to use. So ultrasound is used for surveillance, whereas you have got a LIRADS for the CUS, which is contrast enhanced ultrasound, cross-sectional imaging of with CT or with MR. And please remember, these are all dynamic imaging. That means you have to image the patient in the plain phase without having administered any contrast. Then in the late arterial phase, and that is extremely important, it should be the late arterial phase and not an early arterial phase. Then the patient to be imaged in the portal venous phase and in the delayed phase. And some centers would use a really delayed phase also to enhance the discriminant value of a given observation. Now, the most important hallmark of the HCC observation is that you have an arterial phase hyperenhancement. And this arterial phase hyperenhancement is not towards the periphery of the tumor. So this is a arterial phase hyperenhancement that occurs in the center of the lesion. Now, if you see that any LIRAD lesion which is less than 1 centimeter, and all of us oftentimes contest that MR is better than CT and this particular modality is much better than the other. Please see the right side of this table, and you can see that any observation which is less than 10 millimeter in size, it would not qualify for an LR5. So even if you have all the characteristic features, so all this fight about being able to diagnose with conviction lesions of less than 5 centimeters, they actually cannot stand on its feet. So only when you have got a lesion between 10 to 19 millimeters or greater than equal to 2 centimeters, then you can characterize them completely. Now, what are the various things that you have to be able to discern to be able to tell what this lesion is? One is the enhancing capsule, which you are able to see generally in the delayed phase. Then the non-peripheral washout. So the washout occurs pretty much the same way as the arterial enhancement occurs. That means again, it is in the central part of the lesion. And then the threshold growth. That means in about 6 months time, if a given lesion has increased to by 100% of its original size, then you say that it has fulfilled the criteria of threshold growth. Now, if in this table you see that the additional characteristics might be none, 1 or 2, or greater than 2. So if a lesion is less than 2 centimeter in size, there is no way you would be able to, if there is no APHE or no arterial phase hyperenhancement, you will not be able to assign an LR5 in any circumstance. So that means this by far is the most important diagnostic characteristic of a HCC. Whereas if you have a non-rim APHE, even if the lesion is 1 to 2 centimeter in size, you can diagnose LR5. So here you can see that it is LR4 if there is an enhancing capsule in the delayed phase, or it is LR5 if there is non-peripheral washout, or there is threshold growth, which are defined as more than 100% in a 6-month period. However, when the lesions are more than 2 centimeters, you can see that probably they are malignant or they are definitely malignant. So the confidence of being able to label an observation which is greater than 2 centimeters in size is much greater. So if we use this table time and again, one gets familiar with the nomenclature and as to what to expect in a given observation. So how does this help us? Does it have any bearing on what we are going to do with the given patient? So like I said, that most of the HCCs are diagnosed just by diagnostic imaging. This is one tumor which we have not biopsied, and this is still something that is the standard of care. However, the LIRAD system tells you that if the lesion is LR4, but the background liver disease is such that you don't want to miss an HCC, something which is in the vicinity of a vessel or something like that, then you might want to biopsy this. Similarly, you might have an LIRADS M, that means its imaging characteristics are like that of a malignancy, but not necessarily HCC. That is again a situation in which you might want to have a pathological diagnosis. And now very, very rarely you might want to biopsy just to be sure that what you are seeing in the portal vein is a bland thrombus or a PVTT, because this has got special importance in patients who are being worked up as candidates for liver transplant. Of course, there are other ancillary tools like the increase in the tumor markers or PET avidity for these lesions, which are not the subject of this talk, which can come to your rescue, and they will help you to decide whether the tumor in the portal vein or whether the thrombus in the portal vein is a bland thrombus or a tumor thrombus. So you can see in all other categories, you probably don't need any histological diagnosis, but these are the categories. So especially LIRADS for most centers, if the lesion is quite strategically located, that means it has a predilection to invade a vessel or a surrounding viscera, you might want to biopsy it and therefore preempt the treatment without reaching the stage of LIRADS 5. Now, again, this is a very important graph. So the imaging characteristics are basically aimed at describing an observation to be malignant. Now, this particular diagram tells you that what happens to various observations at various stages of LIRADS reportage. So that means if you have an LR1, this lesion has got a 0% chance of malignancy and obviously then 0% chance of having a HCC. If you have a LIRADS 2 kind of an imaging, there is about 18% chance or 1 out of 5% chance only that this malignancy is going to be a malignant. So this means basically when the imaging is like that of a malignant observation, or the LIRADS reporting system has suggested that this is LIRADS M, And when you have histological proof on these patients, you find that the HCC in this malignant observation would only be 16%. Similarly, for a LIRADS 3 reportage, the malignancy chance 40%, only about a third would be HCC. LIRADS 4, about 4/5 would be HCC. And when it is LIRADS 5, of course, it's a malignant lesion, but almost 9 out of 10 of these lesions, they would be HCC. Whereas if you do not have the kind of APHE, the non-peripheral washout, the capsule and delayed phase and the subthreshold growth that I mentioned, and you are characterizing this lesion as LRM, then there is only a 1/3 chance of this being a HCC. That means some LIRADS M lesions might still turn out to be HCCs. More commonly, these are cholangiocarcinomas or tumors of mixed cellularity. Again, something which has been on the rise in recent years. This is extremely important from management perspective, especially patients who are being worked up or evaluated for transplant, because the recurrence rates are extremely high in intrahepatic cholangiocarcinoma, and therefore this diagnosis must be established with certainty. There are some the ancillary features which come to our aid, and many centers have now started to use this as an abbreviated surveillance tool. So on a semi-annual or an annual basis, they would get only single sequence T2 weighted image for the liver. So no injection of contrast unless you see an observation. Otherwise, you only look for a T2 hyperintense signal observation. If you see one, then you give contrast. Otherwise, this is a good surveillance tool, especially in the context of overweight or obese patients for whom ultrasound surveillance is a challenge. Then restricted diffusion, mosaic character architecture, intralesional fat or intralesional fat sparing, the presence of blood or blood products, and subthreshold growth. So these are the various ancillary features that come to your aid, but please remember the ancillary features can increase the LIRADS grade by 1, but they cannot make you attain a LIRADS 5 status. So that is very, very important to remember, that you cannot go up to LIRADS 5 just with the help of ancillary features. And therein comes the importance of the APHE. So APHE has to be present, and if the lesion is more than 2 centimeters, then this is a no-brainer and the diagnosis is certain.
Sir, sorry to interrupt, sir. 3 minutes to conclude.
Yeah. So this is again a very important feature of LIRADS, which is the response to treatment. So you have subjected a patient to a loco-regional therapy, and you want to know whether this therapy has worked. So you image these patients again, and the timing is dependent again on the LRT, and you are able to not demonstrate similar kind of imaging as it was there at baseline. You say it's a non-viable tumor. It might be equivocal, or if you see a similar kind of pattern of enhancement as you saw in the pre-treatment, pre-LRT, you call it LRTR viable, and this patient will need a repeat thing. So quickly to exemplify what I said. So this is the patient, non-contrast CT. You can see that there is a hypodensity in the right lobe of the liver, also extending up to segment 4. This is the arterial phase. So you can see that there is enhancement even of the portal vein. You do not see a margin to this region, but there is intense arterial phase hyperenhancement. Portal venous phase, you can see that the portal vein, right branch of the portal vein is occluded. And this is what you see in the hepatic venous phase. You see almost the entire parenchyma now looks uniform except for the central part of the lesion. And this is a PET scan, which tells you that this is a PET avid lesion. In the interest of time, I'm not talking about this, but maybe this would figure in the discussion. So this patient is subjected to some treatment, and you can see that 4 months later, this lesion has got a lower hypodensity compared to the baseline lesion, less of an enhancement on the arterial phase. Portal vein phase, you now start to see at least some portal flow in the intrahepatic right branch, especially the posterior branch. And this is the delayed, this is the hepatic venous phase. Again, you can see some capsular retraction of this lesion, but otherwise nothing much of note. And this, you can see the portal vein tumor thrombus comparison at the identical levels. And you can see that there is some resolution of the tumor thrombus, especially it is visible in this part of the scan. So there is some restoration of the flow that you see. Of course, you see something here, and this is an observation which you have to make out and characterize over a period of time, whether this is something new or something which is just the effect of the treatment. Another case, again, you can see in the non-contrast, a central, this is a hypodensity segment 2-3. Now, this is very important. Arterial phase, you see a rim enhancement. So you are not seeing a non-rim enhancement. So you can see the center part of the lesion or observation still is hypodense. In the portal venous phase, some more center part has taken up contrast, and in the delayed phase, more part has taken contrast. So what is this? This is a delayed phase, and now you see that only a very little part of the lesion has not taken up contrast. So delayed enhancement of the lesion, the periphery of the lesion matches almost the surrounding parenchyma. So this is again PET avid, and this is obviously a cholangiocarcinoma that we are dealing with. This patient was subjected to a left lateral segment resection, but see what happens to this patient over a period of 3 months. So you again see this hypodensity, but you see some other observations also in the plane scan. Again, you see the no arterial phase hyperenhancement, and this is the portal venous phase. You start to see some uptake in the periphery of the lesion, delayed even more uptake, and therefore this gives you the diagnosis that this was a cholangiocarcinoma. So briefly about tumor markers, and I think again someone else is going to be talking about this. Not all HCCs will have elevated tumor markers, so you can use the AFP or the L3 fraction of AFP and DCP or PIVCA2, which we have been using in recent times. Role of biopsies, we've not biopsied these patients, and I already mentioned that Leyrat's 4 lesions or Leyrat's M might be biopsied. In earlier years, when PET was not available, we used to biopsy it at times the portal vein also to see whether the thrombus was bland or tumor thrombus. Important is that now you have got actionable mutations in the tumor, and therefore there is a renewed interest in biopsying HCCs. So most of the lesions we should remember, or at least a third of the lesions occur in non-cirrhotic livers, and therefore again the role of biopsies comes in this category of patients. So the practice points, and this is my last slide, the trends in HCC occurrence have been suggesting that there is an increasing number, and this is likely to happen over the next 2 decades too. At least the surveillance strategies for non-cirrhotic HCCs are not in place. And as the therapeutic landscape for management of HCC changes, there is a huge catch-up that is needed for not just imaging, which is reproducible, but also other molecular signatures which the tumor might have, so that we could treat various patients differently depending on the biology of the tumor. Thank you so much for your attention.